Hi y'all, we did our presentation on chronic kidney disease, specifically stages 3 and 4. My name's Emma, and I worked with Bella and Brianna. And here is just a quick table of contents, a little breakdown of what everyone did.
The kidneys have many important functions, including vitamin D metabolism, pH balance, hormone synthesis, excretion, electrolyte balance, and blood pressure regulation. Chronic kidney disease is a shockingly common condition, with 8 to 16% of the world's population having CKD, and in America, this is approximately 37 million adults. The two most common causes of CKD are diabetes and high blood pressure. However, other factors such as genetics, environment, infection, and glomerulonephritis can also cause CKD to develop, but are less common. There are several risk factors to consider for CKD. These include checking if kidney disease runs in the family, if the patient's been exposed to toxins such as chemotherapies that could be affecting the kidneys, if they've experienced multiple UTIs, have had any other associated medical conditions with CKD, or have had kidney stones in the past. Signs and symptoms of chronic kidney disease include blood in the urine, regularly needing to urinate overnight, foamy urine, oliguria, pain in the flank, tiredness, losing weight unintentionally, nausea and vomiting, poor appetite, shortness of breath, leg swelling, metallic taste, and changes in mental state. Something to keep in mind is that many cases of CKD go undiagnosed, especially in the early stages, as this is due to lack of signs and symptoms showing. The image on the slide here shows all 5 stages of CKD, but for our presentation, we're going to be focusing on stages 3 and 4.
Diagnosis of CKD. Patients should be assessed for risk factors of CKD, including diabetes, hypertension, autoimmune disease, nephrotic exposure, including NSAIDs, some antibiotic treatments, and certain antivirals, chronic infection, malignancy, urinary obstruction, and genetic or familiar kidney disease, and abnormal kidney imaging or urine studies. CKD is defined through routine screening with serum chemistry profiles and urine studies or incidental findings. It is less common that patients may present symptoms. CKD is defined by one or more of the following: abnormal serum filtration markers, abnormalities in urine sediment, histology or imaging suggesting of kidney damage, renal tubular, which is a medical condition where the kidneys are unable to remove acid from the blood into the urine, history of kidney transplantation, or markers of kidney damage, persisting for more than 3 months. Testing for CKD includes urine studies that measure both the serum creatinine of GFR, which estimates how much blood passes through the glomeruli, and ACR, which measures the amount of albumin in a urine sample compared to the amount of creatine. A decline in GFR determines the stage of the disease. So stage 3 is defined by 45 and 59, which indicates moderate decrease in kidney function. Stage 4 is defined by 15 and 29, which indicates severe decrease in kidney function. That is compared to the normal levels of between 90 and 120. An increase of ACR indicates reduced kidney functions as well. That is greater than 30, which is also the normal level.
CKD patients are at risk for vitamin C, calcium, phosphorus, and vitamin D deficiencies. In this presentation, we're going to be focusing on vitamin D metabolism. Vitamin D has many functions, but with chronic kidney disease, the one to be most concerned with is how it maintains correct concentrations of phosphorus and calcium in the blood. So we obtain vitamin D from both the sun and through the diet. So as you see at the top of the diagram there, the light, UVB, and heat is being absorbed through the skin. And then at the bottom, the vitamin D from food is transformed into chylomicrons, and eventually both of those pathways will lead to the vitamin D pool found inside the liver. And once vitamin D reaches the liver, that's where it's turned into calcidol, which is the 25-OHD seen beside the vitamin D pool. And eventually that calcidol circulates to get to the kidneys. And on the kidneys, there are vitamin D receptors, which help turn the calcidol into its active form of calcitriol, which is the 1,2,5-OH2D seen in that orange box there. Calcitriol is very important because it controls the absorption of phosphorus and calcium. It also regulates parathyroid hormone, which is secreted by the parathyroid glands in the top right-hand corner. And in a normal patient, the calcitriol is responsible for the calcium retention, calcium absorption, and calcium concentration in the plasma, as seen on the diagram. And when that calcium in the plasma gets to be too low, that's what signals the parathyroid glands to start secreting parathyroid hormone. And in chronic kidney disease patients, the kidneys actually lose the ability to properly turn calcidol into the active form of calcitriol. So, because of this, the PTH will now be out of range from trying to compensate for that feedback loop being broken. And in CKD, parathyroid glands can now produce excess PTH because they can falsely detect the calcium concentration in the blood as being too low. So even though it might not actually be at a low level, the parathyroid hormone can be secreted and the body might not actually need it at that time. So the body then gets the signal to bring calcium from the bones into the bloodstream, and this causes calcifications, weak bones, and bone pain. And this can be especially detrimental if calcification were to occur on the heart or lungs, because this will then start to affect the function of those organs as well. Vitamin D supplements may be beneficial to some CKD patients, but those first must be approved by their medical team since every patient will have different needs and everyone's body will be different.
Medical treatments. There's no cure for CKD, but the management of CKD includes cardiovascular risk reduction, management of hypertension, management of diabetes, treatment of albuminuria, avoidance of potential nephrotoxins, and adjustment of drug dosing. So, reducing cardiovascular risk involves changing one's lifestyles along with medications such as ACE inhibitors, ARBs, and diuretics to lower blood pressure to less than 90 and less than 140 respectively. Now, the presence and severity of albuminuria, which is treated with ACE inhibitors and ARBs as well, but typically not together as it increases the risk of acute renal injury, determines how hypertension is managed. By maintaining an A1C of roughly 7%, which can be accomplished with the use of ACE inhibitors and ARBs, diabetes care can slow the progression of CKD. It is important to avoid nephrotoxins such as NSAIDs, especially when taking ACE inhibitors or ARBs. Because some herbal medicines have been shown to induce renal problems, they should not be consumed. The majority of antibiotics, direct oral anticoagulants, gabapentin, and pregabalin are among the medications that need their dosages reduced. Drugs with little chance of benefits should be avoided by CKD patients, who are generally at high risk for adverse medication effects. Nutrition and lifestyle. Medical nutrition therapy is essential for CKD patients as it may slow down progression. It is important to monitor protein, calcium, phosphorus, potassium, and sodium. Protein intake for CKD patients in stages 3 through 5 should consume between 0.5 and 0.8 grams per kilogram of body fat, all dependent on the presence of diabetes and or on dialysis. Low-protein diets have been shown to improve renal workload. With a low-protein diet, carbohydrate intake may increase, but can still follow the daily recommended intake of between 45% and 65% of daily calories. Fiber is also important in reducing intestinal potassium absorption and reduce cholesterol. Calcium intake should be between 800 and 1,000 milligrams per day to maintain calcium ion balance. Phosphorus intake should be adjusted to maintain normal serum phosphate levels between 3.4 and 4.5 to maintain calcium ion balance as well. Sodium intake should be less than 2,300 milligrams per day to decrease blood pressure and normalize fluid balance. Energy intake should be between 25 to 35 calories per kilogram per body weight per day in order to maintain neutral nitrogen balance and body composition. Fat intake should follow the DRI, which is between 20% and 35% of their daily calories from fat. Limiting saturated fats to less than 7% of daily energy and using unsaturated fats in place of saturated fats is important. Healthful diets include the Mediterranean and whole food plant-based diet. The Mediterranean diet includes high fruits, vegetables, legumes, whole grains, nuts, and olive oil with moderate amount of poultry and seafood, with little red meat, sweets, and processed foods. It improved the profile of kidney transplant patients and is shown to slow down the onset of kidney failure, as beneficial effects on blood pressure and serum phosphate levels. Whole food plant-based diet restricts processed and refined foods and focuses on whole grains, nuts, seeds, legumes, monounsaturated oils, fruits, and vegetables. It emphasizes fiber, which promotes a reduction in serum urea creatinine in CKD patients. Now, foods that align with the nutrition recommendation include brown rice, which is a whole grain, which contains vitamin B, dietary fiber, while reducing intestinal potassium absorption and reduce cholesterol. Another one is quinoa or beans, which is a plant-based protein, which are typically ingested with fiber, phytonutrients, and antioxidants, and are associated with a reduction of blood pressure compared to animal proteins. Peeled Chopped and boiled vegetables such as sweet potatoes can lower potassium content while still maintaining nutritional value due to the cooking method. 2 foods to avoid with CKD include dark leafy greens such as kale, as they are high in potassium, which should be limited with CKD. Canned vegetables such as canned green beans are also high in sodium, which may cause high blood pressure. Generally, physical activity is good for overall health and can help reduce some risk factors such as heart disease. Overall lifestyle should include not smoking, limiting alcohol consumption, and keeping blood pressure in a healthy range.
So I personally focused on the primary research article about low-protein rice for dietary protein restrictions within chronic kidney disease. The study was specifically designed to discover if the usage of low-protein rice would be helpful for patients when they're placed on these low dietary restrictions, which would definitely improve and advance the lifestyle changes for treatment. So the participants, there was 102 individuals. That was made up of 70% males and 30% females. The average age was right around 63 years old, plus or minus a few years. And some exclusions included nephrotic syndrome, if they were pregnant or breastfeeding, if they were ineligible based on their attending physician. So if their doctor said that it wasn't okay, they were taken out, they were excluded. And then severe heart or liver disease with an active diagnosis. So what's so special about this rice? Low protein rice was developed as a food staple with a lower content of protein, obviously. It typically has about 3% to 20% less protein than the typical grain of rice. There's typically 2 ways that they can be synthesized, or a combination of the both. This is through enzymatic treatment or lactic acid fermentation. And then the experimental low protein rice specifics used within this study were every serving had 0.2 grams of protein, so each individual was given 1 serving per day, and this is right around 4% of what ordinary rice can do. The study themselves, all of the participants were given a very strict protocol. This included 25 to 35 kilocalories per kilogram of ideal body weight. And their salt intake was to be less than 6 grams per day. And then their dietary protein was to be right around 0.7 grams per kilogram per individual dietary body weight. There were 2 groups. There was the experimental group, which was the low protein rice individuals. There was 51 participants in each group, along with the control. And for measurements collected, the primary ones included animal plant protein intake. This was measured before and after just through dietary records. So this was a 7-day dietary recording that they took each week before each 4-week check-in with a nutritional council. And secondary was urine samples collected 24 hours before the study. And this was every 8 weeks after it started. So through this experiment, we were obviously looking for these 2 outcomes. The primary, as you remember, is based on protein intake. As you can see from the graph on the right-hand side under the results, that is based on the estimated dietary protein intake. You can see that both the experimental and control group saw a significant decrease within intake. However, the experimental group definitely saw more significant decrease. As you can see based on that graph. And then the secondary outcome is more so based on the urinary excretion. We were studying both protein and sodium. Both groups saw a decrease. However, the experimental group saw a larger decrease within their excretion rate. Research in mind, there's obviously implications and limitations. So the results are suggesting that the usage of low protein rice can be an effective source of properly reaching your energy needs while also reducing dietary protein intake for these individuals as a treatment plan. For limitations, there's actually a handful, but I personally focused on the duration. One other than duration would be the usage of food journaling. There's a lot of room for human error, but based on the duration of the study, it was definitely short term. 24 weeks is right around 5.5 months. So it's a lot harder to take this and generalize the information to see if it's eligible to be a treatment plan for a long-term patient. So a possibility within this is to do a longitudinal study to see how well it can work in a long-term plan. And then this is just a glimpse at our reference list.